Morning.
All right, I guess we'll get going. Whoops. Okay. So this is a tracing from an ACHD patient who had an ASD closure in the past that has a pacemaker. So what do you think is going on here?
So, um, I'm sorry. This is a normal sinus rhythm with a prolonged PR, and every P is followed by a QRS. So I'll say as a first degree heart block, um,
Okay.
um, and a heart rate being around 1, 2, 3, 4, around like 60,
Mm-hmm.
and PR interval being around like 180 or 200 milliseconds.
You think it's that short? How
I'm
much is a
sorry,
big
sorry,
box?
yeah, big boxes. Two big boxes or 2.5 big boxes. So 300 divided. Oh my goodness. Am I calculating it wrong? Well, small 0.04.
Right. So just remember
Yeah,
always, each box is 200 milliseconds, right? So
correct.
it's at
Yes,
least 200,
400.
two big boxes, right? So it's over
Yeah,
400 milliseconds,
yep,
maybe even closer to 500 milliseconds.
correct.
Do you think it's really sinus? Is there anything that gives the lie to the notion of
Um,
sinus rhythm?
mm, the p-axis in the 1 and AVF is positive.
Okay.
That's why I was thinking it's a sinus rhythm.
Do you see anything in V1 that might,
Uh,
I agree with your statement. It is upright in 1 and F, like sinus.
we mean there can be some p is negative or like biphasic. Oh, it's pacing. Sorry, it's a
Yes.
paced rhythm. My bad.
Yes.
Let's see the
That's
pacing
right.
spike. So yeah, it's like a paced,
Right.
a paced, and with an AV delay, which is prolonged, but native sign like native beat,
Right.
native through AV
Native
node.
native
Yes,
conduction, you mean?
yes, yes.
Okay. So does anybody have any thoughts on what genetic condition could be explaining this, or is it possible that the first degree block is from the repair itself?
Like a sinus venosus AST or
Sinus venosus is actually less commonly associated with first degree
okay,
heart block, right? Because it's usually a more superior defect. Where is the AV
okay.
node located?
It's in the apex of the triangle of Koch.
Uh-huh, which is
Um,
bordered by what, since you brought up that Nice term.
So it's um, tricuspid annulus inferiorly, superiorly by the coronary sinus, mouth of the coronary sinus, and tendon of Todaro on
Right.
the, yeah,
That's right. And so that's very close to the AS to an ASD, but
right,
usually we don't see ASDs causing heart block. I have seen it on
right.
one or two
Okay,
occasions, but it's uncommon.
okay.
But any genetic conditions or other conditions that could be associated with first degree heart block and
Like
ASD?
Holt Oram syndrome.
Yep, yep, that's right. Holt-Oram syndrome. So does anybody know what gene is associated with Holt-Oram syndrome? It's a good board's question. Any thoughts, anybody? So it's the T-box gene, TBX gene, that's associated with Holt-Oram syndrome. And people with Holt-Oram syndrome very commonly have first-degree AV block, independent of surgery. They also can have sinus node bradycardia, which is probably sinus node dysfunction, which is probably why this patient was paced, is that somebody made a determination that this patient had sinus node disease, and that can be independent of the congenital heart surgery. Later in life, these patients are at risk for the development of atrial fibrillation. And they can also have progression of their heart block, which is probably true of anybody who has a PR interval of 400 or 500 milliseconds. Um, so, what are the most common congenital lesions associated with Holt-Oram? There are, and what percentage of Holt-Oram patients do you think have congenital heart disease? Mix a little cardiogenetics in with today's EP.
I just know that they can have limb abnormalities and Holt Oram.
Yes, they can
Um,
have radial bone problems or
yes.
absence. Uh,
I'm not sure about the
so
percentage.
about 75% or three-quarters of people with Holt-Oram syndrome have some kind of septal defect. ASD is by far the most common. Second most common would be VSD. So if you ever see an ASD patient who has heart block or first degree heart block, you should immediately in your mind's eye be thinking, is this Holt-Oram syndrome? And you should be asking yourself about the possibility of a T-box gene as a mechanism. Now, the question is, this person happens to have a dual chamber pacemaker. Um, is this better or worse than, like, we could turn on the V wire, right, and have A-paced, V-paced rhythm. How do you make the determination as to whether, right? So we always think in general, conducting through our own native conduction system is superior to apical or septal pacing, unless you're doing, conduction system pacing, like left bundle pacing, which is not the case in this patient. How do we decide if leaving this person with a PR of somebody presumably decided that a PR of 480 was better than a normal PR interval of like less than 200? How does one decide that? So really, it has to be made on a case by case basis, really related to how the patient is doing and how they feel, and also what their conduction is like. Although we're seeing the patient during a 12 lead EKG and we see, or 15 lead EKG, and we see that the PR is what it is. The question is if the patient were to start exercising, would the conduction persist? So the first question is this patient, conducting at faster heart rates? Or in other words, we see that at a rate of 60, we conduct 1-to-1, but maybe at a rate of 80, the patient is wenky-bocking. So that would be an issue. The other issue, so one could do a stress test, or one could do a Zeo patch or a Barty device or a Holter to see what happens to conduction at different times of the day during different levels of exertion. Um, And then one could potentially see uh, how the patient is feeling also. If the patient says they're tired all the time, or you could also do a stress test and sort of see what the cardiac output and the exercise output is, what the VO2 max is with exertion. There are different ways to, and that would also allow you an insight into the PR interval and conduction during exertion. Sometimes people with first degree heart block, when they exercise, the PR will shorten very substantially. And so it is useful sometimes in a patient like this to do that. In this particular case, the patient was actually programmed with the so-called MVP, or minimized ventricular pacing modality, on in the pacemaker. Does anybody know how that generally works? Okay. So in an MVP pacemaker, which is really only I believe, available in Medtronic devices. What you do is you program the device AAIR, in this case, atrial pacing, atrial sensing inhibitor, inhibited by intrinsic activity and rate responsiveness. But the device is programmed that if there is a non-conducted P wave, it will convert to DDDR. And then it will, every period of time, not pace the V to see if there is conduction again. And if there's conduction, it will go back to AAI or pacing from DDD. And the theoretical benefit of this is for somebody who has intermittent conduction or maybe second degree heart block, but is conducting a good part of the time. The benefit is exactly what the modality sounds like: minimized ventricular pacing. Ventricular pacing has been associated with development of cardiomyopathy. Cardiac output may be reduced based on where the pacing is done. Maybe less efficient way of depolarizing the ventricles. Cardiac output could fall. And most importantly, or as importantly, every time you pace the V, you're using battery. And as we've discussed, the pacing of a pacemaker is actually the largest expenditure of energy of a pacemaker. So if there were a way to minimize pacing of the ventricle in a dual chamber patient, that would clearly be a benefit for many reasons. And so in this patient, interestingly, when I interrogated their device, the patient is A-paced, V-paced 18% of the time, and is A-paced alone 82% of the time. And so that's great in terms of minimizing pacing and extending the longevity of their battery, of their pacemaker. Now, anybody have any thoughts on any downside of somebody who is going back and forth between V pacing and conducting with a long PR? Any thoughts on why that might possibly be disadvantageous? I've sort of now just mentioned all kinds of nice things associated with that.
Would it be annoying to the patient that they lose synchrony?
Yeah, well, it's not a matter of losing synchrony, but they do feel the difference. At least some patients can feel the difference between pacing and conducting, and they don't like it. Now, interestingly, this patient had no sensation of any changes. Could basically didn't, essentially I was informing them of the fact that there was a change in the program automatically 18% of the time. But some patients I've had really are bothered by it. I have one patient with Epstein's anomaly, and she can't stand it when it changes. So, in fact, I programmed the patient and they had to come back like the next day because they couldn't stand the flip-flopping in the rhythm. And that's something that all electrophysiologists need to be very aware of when they're ever making a change in a patient's pacemaker program. You have to be very careful that the patient will not like the change and will feel very uncomfortable very rapidly. And so I've had cases where I've turned on rate responsiveness and patients gotten very uncomfortable, or I've changed the sensitivity of the piezoelectric crystal so that smaller amounts of activity raise the heart rate, raise the lower rate limit faster. And patients can oftentimes they can feel it very suddenly, and they don't like that feeling. So the point is, people generally get very used to their modality. It's interesting. I think we've talked about this in the past. Although we often turn like this patient has rate responsiveness on their pacemaker. But the interesting thing is, if you look at the distribution of heart rates for this patient, um, I think 82% or 85% of their heart rate was between 60 and 75. Even though rate responsiveness was on and the piezoelectric crystal was programmed to go up to about 100, I think to 110 with activity. The vast majority of the time, the patient was essentially bradycardic, albeit less bradycardic than they would be without a pacemaker. If I were to change the sensitivity, so if you or I, as people with normally functioning sinus nodes, had to live with a heart rate that essentially 85% of the time did not exceed 75 beats per minute and was mostly in the 60s, we probably would not feel well, because we're used to having faster sinus rates. But patients generally accommodate very well to bradycardia. And in my experience, they don't really like it when you try to make it more physiologic. Now, is it possible that if we were more aggressive about trying to make it more physiologic earlier in life and patients were used to feeling the heart rate vary more regularly, would they be less intolerant of changes or increases in their heart rate? It's possible. But interestingly enough, most adults or young adults with a slower paced rhythm feel completely fine and actually do well on exercise stress tests, although maybe they would do better if they had better chronotropic competence. I don't know. Probably so. But it's an interesting observation. Okay, so any questions on any of this? All right, move forward. So this is another fellow question. This is a now graduated fellow, does not work at this institution anymore, but I got this text a few months ago. Sorry to bug you. I missed 1 EKG for this heart block girl that to me looks like Mobitz 2. My question to the group is, do you agree? Since you don't know which fellow this was, you can feel free to agree or disagree. What do we think?
Just taking a look at this, my instinct is that this might be a blocked PAC. But I'm
You're
struggling.
looking over here, is that right?
Correct, but I'm struggling to see exactly where a P wave might be buried in the preceding T segment. Um,
Well,
but
if you look up here, right, this is the benefit of having a 12 lead, right? You could have thought or imagined that if, for example, you look at just V1, you could imagine that this is all part of a T wave, right?
yes,
But it's not. And the reason you know it's not is because if you look in this lead, you see that clearly the P wave is starting after the T wave. The other thing that goes against it is if this were part of the T wave, the QT interval would be quite lengthy in this patient. Patient would have long QT syndrome, which is possible, of course. You don't know anything about this patient. But I think that if we look in some of the other leads, for example, in this lead, in lead 2, also, you can sort of have the sense that there's a P wave that is superimposed on the T wave. It's unusual for the T wave to have this kind of morphology where it starts with a small bump and then has a bigger bump. So I think we can say with some confidence that this is a sinus P wave and that the T waves, for whatever reason, in this patient are relatively flat. So any thoughts? So the person who sent me this text is clearly asking the question,
right.
is this P wave a representative with no QRS following it? Does it represent, Mobitz 2 block? And I will tell you for the sake of conversation that it is on time. It is not early. Well, is it? Maybe I'm wrong. Wouldn't be the first time. Yeah, I
Yeah,
think it actually is a tiny bit early. It is early. Good observation, Blood. So what do we think about this P wave?
So if it is a little early, then it could be a Lux PAC.
Yeah, it could be. I mean, it's hard to say because we only have couple of leads, right? We don't have the full 12 lead for this one beat. So it could just be a block PAC. If it is on time, let's assume for the sake of conversation that it is, because I think the reason that the fellow asked me this question is because they thought it was on time. And take out some calipers here on my screen. See, this is the downside of doing this on the computer. It actually is on time. That P wave, just for the record. So that P wave is on time. So it's not early. So what do you think? Mobitz 2, Mobitz 1, third degree?
If it's truly a dropped QRS, then I would say probably Mobitz type 2 because it's not like the PR interval is prolonging and it does seem to just be a random beat, but I think it's a little odd to just have one dropped beat in this 10-second rhythm strip. I would expect to see at least one other.
Yeah. Ultimately, so it's somewhat of a trick question. It's very difficult to know, right? Because as you astutely point out, there's only one P wave that's not conducting. And it's possible that if you took out calipers, I actually think that there may be a subtle prolongation in this PR interval relative to this one, but you would really need to sit down with calipers and figure that out. This type of beat comes up very often on Holters or Zio monitors, where somebody in the middle of the night, for example, will have one non-conducted P wave. And the question will often come up, and I'll be asked, is this an example of Mobitz 2? And the short answer is that without the presence of a His catheter, in order to know if there is block in the AV node or in the His-Purkinje system, it's not possible to really know definitively what this is. But generally speaking, if I see only one P wave non-conducting, I generally don't get too bent out of shape over that. And I will usually assume that it is Mobitz 1 rather than Mobitz 2. But one of the ways to help is to look at other strips of the patient at different times in order to see if there are other examples of non-conducted P waves. For example, if you saw other sequences where it was more obviously Mobitz 1, you might and this is the only sort of iffy example, you might be more inclined to say this is probably Mobitz 1. On the other hand, if you saw a number of examples of P waves that are not conducting with absolutely no change in the PR interval prior to or after, then you might be more inclined to think that it is Mobitz 2. I think, so sometimes, you want to see what else is going on in the patient's telemetry or Zio or whatever. In this case, we decided to say that this was most likely Mobitz 1. But honestly, we don't truly know. But it is an interesting sort of mental exercise. Any questions about this? Okay. Forward. This is post-op mitral valve replacement. Patient is programmed through their temporary wires DDD. And the question for the audience is, what is wrong here? Any thoughts? Kitoki, do you have any thoughts on what might be happening here?
Good morning, Dr. Paz.
Hello.
I see for first 5 beats,
Point at it. Uh-huh.
it seems that there is spike before. There are 2 spikes, so there's A pacing and B pacing. For the first beat, I don't really see a P wave, but I see one for the second, for the third. I don't really see that very well.
So
See again for
when
the
you say,
fourth.
you mean you see the pacing spike, but you don't see a P
Yeah,
wave afterwards. So
yeah,
what would be
yeah.
another way of saying that? I agree with you, but
Uh,
how would you describe it? There is an absence of what?
like there's a loss of capture of the P
Right,
waves.
exactly.
Yeah,
There's an absence of atrial capture, and you can say that fairly confidently in this beat because you have a 12 lead to look at it, and you really don't see a P wave after this. And yet, I agree with you in this beat, though it does seem like there's a P wave afterwards. So one observation that's abnormal is the atrial capture threshold is clearly high because there's intermittent atrial capture. Would you agree with that statement?
yeah.
Okay. Why don't we just get the ventricle out of the way? Is the ventricular lead working all right, you think?
I think so. There are like ventricular pacing spikes, and then there are QRS complexes
Right, I
after.
agree. One little
Yeah,
subtle abnormality or interesting observation is you look at these 3 beats and they're narrower than these beats.
yeah,
And I
yeah,
believe that's because the patient actually had Mobitz 1 and Mobitz 2 block. And so I think that might be combination of intrinsic conduction as well as ventricular pacing. But that's okay. You might ask, well, if it was going to conduct, why did it pace? And the answer is that, you program the pacemaker with a certain AV delay after the atrial pacing, and it's going to pace unless it sees a QRS. And what can happen is, even though the ventricle may start depolarizing, the temporary wire may be very distal on the ventricle, and so it doesn't actually see that the ventricle is starting to depolarize because it takes time to go from, let's say, the crux of the heart to the apex where the lead may be sewn to the heart. And so there is pacing that starts in the lower chamber in the ventricle through the wire because the wire has not yet seen the ventricle depolarization. If the wire were presumably higher up in the heart or closer to the conduction system, it might have sensed that and not paced the V. But there's no harm in this because it's just basically a fusion between the paced beat and the intrinsic beat. Now let's just talk about the atrial again. So you have astutely pointed out that there is a intermittent lack of atrial capture. Is there any other problem with the atrial lead? And I will say to you that there is. So, what do you think it is?
I think it's for the last 2 beats. I don't really see a pacing spike.
Okay, but is
Um,
that okay? I mean, let's
it,
say I set the program at 110 as a lower rate and the atrial rate was 140. Would you see an atrial pacing spike?
I wouldn't.
Okay.
Um,
And in
mm,
fact, right, you see that there are P waves before each of these QRSs, right? The
yeah,
longish PR, QRS, P wave, QRS. You can also see the P wave in this lead AVR. So in this case, in these beats, it seems like it's A sense V pacing. Somebody
mhm.
nicely put little arrows on all the pacing spikes, so they clearly noticed that there was pacing in the V, but not in the A. But what do you make of this beat here? What's happening here? So we clearly see the pacing spikes, right? Well, where is the P wave relative to the pacing spike?
It's before the
Right.
pacing spikes.
So what does that tell you about the atrial lead? So
Um,
we know already that there's intermittent capture. What do you think
yeah.
about the sensing?
I think so. There is a P wave, but despite the P wave, there's a pacing spike.
Right. So what does
So
that tell you about the pacemaker or the lead?
that this is oversensing.
Oversensing? No, it's the opposite.
Sorry, it's the undersensing then.
Right. Why is it undersensing? What's the proof of that?
Because despite the P wave, the pacemaker thinks that there is no P wave and it's not able to sense that, and that's why it puts that
Pacing spike.
it's trying to it puts that pacing spike.
Yeah, exactly. That's exactly right. And so basically, this is a very nice demonstration of a lack of atrial sensing. If it was sensing properly, there should be no atrial pacing spike, and the paced ventricular complex should be earlier. But because it doesn't sense the atrial activity, it just paces the atrium as if there were no atrial activity occurring. And this happens a few times. Here's another example where there's a P wave inscribed on the end of the T wave, and you see that it's pacing, like 180 milliseconds after that P wave, which it should not be if it sensed the atrial activity correctly. So this is an example of a patient who has a properly functioning ventricular lead, but the atrial lead is neither sensing properly or capturing consistently. So it's intermittent sensing, intermittent capture. And this could theoretically be dangerous, right? Like in this example, we see how it's trying to pace on the P wave. Now, in this particular one beat, this is not dangerous because pacing on a depolarized atrium is going to do nothing, good or bad. However, pacing on and by the way, that's the reason why the QRS is narrower, right? Because the P wave is conducting with a longer PR, so there's a greater period of time for the conduction to occur, which is why the QRS is narrower, why we're seeing, because the patient clearly had some degree of first-degree heart block. So there is, because it doesn't sense this P wave, it paces into the P wave, and there's actually more time for the conduction to occur between the programmed AV delay on the pacemaker. So that's why we're seeing a fusion here. So basically, this is an example of a poor sensing, intermittent sensing, and intermittent capture. And so the way to try to fix that would be to make the setting more sensitive, meaning lowering the number. Unfortunately, in this case, the pacemaker sensitivity was at the maximal sensitivity, which on the temporary devices is 0.4 millivolts. And so even at that setting, it was only intermittently sensing. We see that it does sometimes sense, right? These beats are clearly A-sense V-paced complexes, but this clearly does not. This is, again, one of the reasons why I don't love A-sense V-paced rhythm in temporary wires, because one can have a page of this where the pacemaker is working perfectly and then have this. I mean, this is a nice example that literally in 3 beats, 1/3 of them is not being sensed properly. And that can happen with temporary wires. Now, we talked about how the reason for that is because the surgeon intentionally tries to sew the lead softly or gently to the atrium. So the fact that the atrium has very little myocardial mass means that the electrogram recorded is always going to be smaller than the ventricle in the majority of cases. And B, the fact that the surgeon is intentionally attaching it very gently to the atrium because they understand that it has to be yanked out at the end of the hospitalization and they don't want to have an atrial tear. Those two combinations it's not a shock why atrial sensing off temporary leads can sometimes be exactly like this. So what we chose to do in this case was to just change the patient to a VVI modality, which thankfully was hemodynamically well tolerated. All right, any questions about this? All right, and kudos to Vlad, who actually figured all this out in real time at the bedside while the patient was still relatively hemodynamically unstable and was able to ferret this out and get the patient properly programmed quickly. All right, I think with that, we'll stop then for the day. Hope everybody found this of some benefit and hope everybody has a great day. See you soon. Bye-bye.